All right, we will start the beginning for this event. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to the International Guest Lecture, Faculty of Medicine, Universitas Sebelas Maret, with the theme Physiology Changes in the Cardiovascular System. My name is Dyonisa Nasirochmi, and I will be your moderator for today's event. I would like to personally welcome the Honorable Prof. Reviono as the Dean of Faculty of Medicine, Universitas Sebelas Maret, and also Dr. Eti as the Head of Undergraduate Study, Faculty of Medicine, Universitas Sebelas Maret. I will also like to welcome our honorable speaker for today, Professor Cheng, and also Dr. Dono. It is a pleasure to have you joining us today. And for all students, welcome and thank you for joining our international guest lecture. Ladies and gentlemen, I would like to read the agenda first for today's event. First, an opening session including the singing of National Anthem of Indonesia and a welcoming and also an opening remark from the Dean of Faculty of Medicine. Next will be a lecture from Professor Cheng, followed by a Q&A session, and also by Dr. Dono, which will be followed also by a Q&A session. First, we will hear the next agenda is singing of the National Anthem Indonesia Raya. Thank you. All right, to start this event, we will have a welcoming, also an opening remark by the Dean of Faculty of Medicine, Universitas Sebelas Maret. To Prof. Reviono, the time is yours.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Pada yang terhormat pembicara, especially I like to thank you to Professor Dr. Cheng Ming for joining and giving lecture, dan juga Dr. Dono Indarto pada acara International Guest Lecture yang kali ini akan mengambil tema Physiology Changes in Cardiovascular System. Acara seperti ini sangat kami harapkan karena bisa memberikan suatu tambahan ilmu, terutama ilmu secara internasional, update dari level internasional yang kali ini mendatangkan guest lecture dari Universiti Malaya, Malaysia, yang universitas yang saya kira reputasinya cukup tinggi. Ya, secara umum kami harapkan para mahasiswa yang hadir kali ini, S1 maupun mungkin yang lain, bisa mendapatkan ilmunya dan untuk bisa menambahkan pengetahuannya. Baik, saya kira tidak panjang lebar, ini sudah cukup banyak yang hadir dan juga waktunya juga sudah akan segera kita mulai. Maka dengan mengucapkan Bismillahirrahmanirrahim, saya nyatakan bahwa International Guest Lecture dengan tema Physiology Changes in Cardiovascular System dimulai. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Yono, for the welcome and also the opening remark. Before we proceed to the main agenda, I will invite all speakers and all participants to turn on your camera first. We will have a picture first. To Dr. Ratna, I would like to ask help for the pictures.
Okay, we will start to take photo.
Maksimal per usia itu kan tembus.
Yeah, you can open your camera so you can. Okay. First page. 1, 2, 3. Smile. Second page. 1, 2, 3. Okay. The last page. Okay. Finish, Dr. Dyonisa.
All right, thank you, Dr. Ratna, for your help. Right, in the short time, we will have an interesting discussion about the physiology changes in the cardiovascular system, in which I believe it is very important to have a strong basic of understanding about this topic. So today, we will hear the first presentation and have a discussion with an expert on the subject, Professor Dr. Cheng Ming. Professor Cheng is a professor in the Department of Physiology, Faculty of Medicine, Universiti Malaya, Malaysia. Professor Cheng obtained his PhD in Liverpool University in the area of human immunology using the human model of placenta. His research interest focuses on immunogenic epitopes, natural physiologic autoantibodies, free radical antioxidant, immunomodulation of oxidized lipoprotein. Also, in his academic activity, Professor Cheng has published around 17 physiology learning texts, including a multi-authored nursing textbook on anatomy and physiology. So today, Professor Cheng will talk about the cardiovascular system physiology with renal function and blood pressure regulation. So let's now. Good morning, Professor Cheng. How are you?
Hello.
Hello. So, all right. So before we go into the presentation, I would like to kindly remind all the participants, if you have any question, please chat in the chat room, and we will discuss it after the presentation. All right, Professor Cheng, so the next 30 minutes is yours.
Thank you very much.
Start.
Yeah, thank you very much for sharing, and thank you, Professor Divyono, for joining us this morning. So let me just share screen now and share with you. Okay, this morning I've been asked to cover in a short time an overview of the essentials of cardiovascular control of blood pressure. And I have entitled this to be a more integrated topic because the control of blood pressure involves not just the cardiovascular system, but also the renal mechanism. So this is my title, and I will be talking a fair bit on the involvement of both the nerves and the hormones. So you could call this the cardiorenal, blood pressure, neuroendocrine regulation. So for the students who are taking notes, let me just say that I will be happy to send this set of PowerPoint slide to Dr. Ratna. So you don't have to be in a hurry to take notes, and you can use that as a reference, and maybe we can follow up with some communication. Yeah. So I managed to get this picture. I hope this is the right picture of your university, but I don't know which building this is. And I just want to say also that my first contact with Universitas Sebelas Maret was at the International Physiology quiz that I chair. And this was a team that came, I think, about 3-4 years ago with Dr. Ratna. And so I'm very happy to be able to touch base again with the university. So, and of course, we are living in unusual times. And in the last 18 months, most of my time, I'm sitting here in my living room, zooming across the world to give some talks here. And in that period also, my grandson was born during the Corona year, and he is also quite restricted. He doesn't see any other human beings besides his parents. And so next slide is just to show a picture of him. And here he says, it's the dreaded virus. Yeah. Anyway, so this morning we're talking about cardio-renal physiology of blood pressure control. So I will address this talk in a few questions and then elaborate on what I have to say. Yeah. So as I said, we are looking at the neurohormonal integrated control involving both the cardiovascular and renal system. So first of all, let me just list down the kind of hormones that are involved. And these are familiar names. And the hormones come under different groups. You have angiotensin, a peptide. You have this neurohormone, ADH. You have 2 steroid hormones from the adrenal gland, aldosterone and cortisol. They are also involved in blood pressure control. And obviously the popular adrenaline, which comes from the adrenal medulla. You can add on to this list another hormone, which is also a peptide called atrial natriuretic peptide, which comes from the heart. Okay, so that one is also involved in the control of sodium balance, which indirectly affects blood volume and blood pressure. So the first question, as a reminder, is how does the rhythmic cardiac pump maintain a continuous flow to the tissue? So the pump is not a constant pump. It has to relax, it has to fill up again, and it has to pump. So obviously we talk about a systolic pressure during contraction, and we also have a diastolic pressure, which is a function of the recoil of the elastic arteries, which maintains the blood flow to the peripheral circulation, even though the ventricles are no longer contracting. So just to remind ourselves, so this is the profile that you see in all textbook, where you have the systolic pressure and the diastolic pressure. And this is the driving pressure that distributes blood flow from the left side of the heart to the right side. And so the pressure profile drops quite steeply, especially at the point of the arterioles. And this is because these are the major resistance vessels. And so you find the sharpest, the steepest drop in the pressure. So this is a pressure gradient profile that all students would recognize. Now I want to make one point here, which we will come back to again, and that is the upstream effect and the downstream effect of any constriction of arterioles. So when we say that the arterioles constrict and the blood pressure increase, we are talking about an upstream effect. Okay, but at the same time, in the downstream, in relation to blood flow, the capillary hydrostatic pressure actually drops whenever you get a arteriolar constriction. So keep this in mind, because I'm going to come back to this when we talk about one intermediate compensation for blood pressure control during hypovolemia. Okay, so let's move on to the next slide. So just to remind the students, so this is the formula that every student would memorize, even if they do not know where this was derived from. Blood pressure is cardiac output times total peripheral resistance. Okay, it's actually derived from the basic hemodynamic formula of flow equal to pressure over resistance for a single blood vessel. So let me elaborate on this. So blood pressure is cardiac output times total peripheral resistance. So the basic hemodynamic equation is the flow equal to perfusion pressure over the resistance. Now this is in one single tube. Okay. Now if you look at the overall systemic circulation from the left side to the right side of the heart, then the flow becomes cardiac output. Okay. And the blood pressure would now be basically the mean arterial pressure, because on the right side of the heart, the pressure is about close to zero. So basically we're talking about the mean arterial pressure on the near the aorta, or the mean aortic pressure. And obviously now the resistance factor becomes, in the whole of the systemic circulation, the total peripheral resistance. So if you rearrange this formula, this relationship, you find that blood pressure is equal to, blood pressure is equal to CO times TPR. Okay, just a note here, and that is when we talk about the pulmonary circulation, because of its unique characteristic, is by definition it is not part of the systemic circulation. So just a little bit of interesting digression. Since I'm my grandfather came from China, so although I don't have a Chinese education, so this is the this looks like the character for the word heart in Chinese. Okay, so now Chinese images are interesting in a lot of cases because it represents the object. So this character for heart in Chinese, you will see, you can recognize that this looks like the ventricle, right? And the blue one could be the venous return, and the red one could be the cardiac output. So this is the Chinese character for heart. Okay, so let's go back to this equation here. Blood pressure is cardiac output times total peripheral resistance. So these are different kinds of muscles are shown here. Here is cardiac muscle, the myocardium, and here is obviously a function of the smooth muscle, the total peripheral resistance, the arterioles. And I'm going to mention in a short while the involvement even of skeletal muscle in the overall systemic regulation of blood pressure. Okay, so cardiac muscle, obviously, smooth muscle in total peripheral resistance control at the arterioles, and there is an involvement in skeletal muscle, and this is obviously we are talking about the muscular pump that drives the venous return into the ventricle. Okay, so just to so this is a picture of Ernest Starling. I like to show students picture of their physiological heroes to give them a sense of heritage. So obviously, when we talk about controlling cardiac output, which is a factor in blood pressure control, one of the factors is obviously venous return. And this just shows you that during physical activity, when the muscles are contracting, it actually promotes a better venous return. And that also will contribute to a better stroke volume and cardiac output. This is obviously called after Starling's law of the heart, or Starling's mechanism. Now, in considering the neuroendocrine integrated control of blood pressure, when we look at the hormone adrenaline, which obviously affects the heart, okay, adrenaline is obviously secreted from the adrenal medulla. We actually think about the whole system called the sympathomedullary system. Okay, so the sympathetic nerves directly affects the heart, but the sympathetic nerves also stimulate catecholamines from the adrenal medulla, and then the circulating catecholamines enhances the direct effect of the sympathetic nerves on the heart. So I've shown this in a triangle form. So this is from one of my books. This is the way in which I've tried to organize small pieces of information now to give a mental image for students. So this is what I call a physiometric picture, a combination of physiology and geometry. So this physiometric picture shows you that the sympathetic nerves, for example, directly affects the SA node to increase heart rate. It also directly affects the ventricles to increase contractility, but indirectly, it also stimulates the adrenal medulla to release adrenaline, catecholamines. And these catecholamines produce the same effect on the heart rate as well as on the contractility. Okay, so this is your sympathomedullary system. Okay, let's ask the question now. So this is basic long-term as well as short-term control of blood pressure. So we normally discuss this under short-term, and this is when we do the cardiovascular physiology. And then in the traditional curriculum, the long-term control is actually part of renal function. And that normally comes in only about 2 months later. So sometimes in the traditional curriculum, the students tend to segregate cardiovascular control from renal control. So I hope to show you that actually, although we call it short-term, long-term, and there is intermediate term, they're all actually not sequential, but actually part of an overlapping picture of blood pressure control. So it is useful when we are learning or teaching blood pressure to try to integrate both the baroreflex short-term with the renal long-term control of blood volume. Okay, so this is, if you're wondering what this playing card here is, so sometimes I tell students that if they are creative and innovative, they can use playing cards and maybe design a game and call it cardology, not cardiology, playing cards, okay? So anyway, going back to this equation, so this is cardiac output times TPR. So cardiac output is obviously a function of the heart. TPR is a function of the blood resistance vessels, the arterioles. So blood pressure control, short term, would be the rapid neural mechanism. It has to be a rapid compensation. And then the long term involves a longer time, obviously, but it is very effective. It obviously involves hormones. So you have a neuroendocrine integrated control. And this control of blood volume obviously is linked to body fluid sodium balance. When you change the body fluid volume, you also change the sodium balance. And so the kidney's role in regulating sodium balance is linked to the control of ECF, extracellular fluid volume, and blood volume. So we are in the realm of what I call kidney land. Okay, sounds like Disneyland. Okay, so let me bring you to kidney land in a short while. Okay, so again, another physiometric diagram to highlight that controlling sodium balance by the kidney is linked to controlling blood volume. So the amount of sodium that is excreted by the kidney changes. And these changes are not random. They are not just excretory sodium, but they are compensatory response to changes in the sodium status or the blood volume status. So, so let me see here. Okay, so this is again another picture. So the sodium balance is linked to the volume of ECF. And of course, since blood volume is a component of ECF volume, we are saying that sodium balance affects blood pressure. So this has something to do with the recommendation even by people who have no biology background to say that your dietary sodium can indirectly affect your blood pressure. So the link is actually through the changes in the body fluid volume. Okay, so let me just show it here. So the renal control of blood volume, which then affects blood pressure, is obviously through regulating total body sodium or sodium balance. So this involves those students who have done endocrine will always remember this very exotic long name, Renin-Angiotensin aldosterone system. Okay, and the activation of this always serves to conserve sodium. And so whenever your volume drop, when you are in negative sodium balance, you always activate the renin-angiotensin aldosterone system. Okay, and this activation of the renin system is one of the key activator. It's actually a nerve. This is your renal sympathetic nerve. Okay, so so let's go back to your rapid response. Your rapid response involves triggering the baroreflex, and that activates the renal, the sympathetic system, which includes the renal sympathetic nerve. And this is the trigger for the renin release, which then helps to conserve the sodium and recover the volume when you are in hypovolemia. Now, to add to the complexity of this key hormone, renin, the next slide is a summary of the 3 key pathways that renin is increased whenever you are in hypovolemia. Okay, so I tell the students before a fairly complicated slide, please fasten your seatbelt so that, anyway, here you are. Okay, so again, you can look at this more carefully. So this is, so let's start from the top. So when you are in hypovolemia, decreased plasma volume, you are in negative sodium balance. So before you look at what is in the middle here, look at what happens at the end here. So the kidney's response is always to conserve the sodium by excreting less sodium because you have already lost total body sodium when your blood volume drops, okay? And so if you want to conserve sodium, you obviously want to activate renin, which is in the middle here, okay? And at the same time, all 3 mechanisms will increase renin when you are hypovolemic. One, as we just said, is the renal sympathetic nerve here. This is the first mechanism. The second mechanism is through the more convoluted macula densa mechanism, okay? That also secretes the paracrine to release renin. And at the same time, there is this direct sensing of the drop in the arterial pressure when you are hypovolemic, and this stimulates what is known as the intra-renal mechanosensors, and that also triggers renin. Okay, so this is the summary of the 3 renin pathway. So what we are saying here is in this integrated cardiorenal is that the kidney and the cardiovascular system are talking to one another. There is a communication between the kidney and the heart in maintaining blood volume. So I put this in a little comic cartoon, not cartoon, sorry, it's a conversation between the kidney and the heart. So the kidney is called Reno and the heart is called Mayo. So I hope you can appreciate this little dialogue to highlight the role of the kidney in regulating blood volume, and then that blood volume is necessary for the heart to pump a sufficient cardiac output. So this is for your interest. Oh, sorry, just skip this. So Reno, the kidney is talking, I make sure you have enough blood, talking to the heart. And then the heart says, huh? I thought I'm the one that supplies you with blood. And then Reno, the kidney says, that is true, but I am the one that ensures that the blood volume we share is always enough. So this is the explanation here, the physiology. So those of you who are creative, you can try to draw characters for this, which I have been doing with my own students. Yeah. So let's move on. So as I just said, although we talk about short-term baroreflex neural mechanism and long-term renal mechanism, they are not sequential, okay? They overlap, they are not separate events. The neurohormonal mechanisms are integrated. So let me summarize a little bit of information here. So if you look at the role of the sympathetic nerve, which everybody knows is involved in baroreflex, we see that it is also involved in the long-term renal, as well as we're going to introduce the intermediate-term control. So this is the one, sympathetic nerves, which are always activated as a result of baroreflex. You get this is familiar. Then as we saw here, the renal sympathetic nerve stimulates renin as one of the 3 pathways. So that obviously restores volume and sodium balance. Now I'm going to show you something called the intermediate term related to sympathetic nerve stimulation. And this involves something called the transcapillary fluid shift, which helps to preserve blood volume. Now let me explain what this is here. So the next picture, okay, if you're wondering why this tooth is here, yeah, this is a model of a tooth. This is because some of these slides was given to a group of dental students. So I put a picture of the tooth. So I'm reusing the slide. Okay, this is the picture of your microcirculation. This is an interstitial fluid. This is a plasma volume. So when you are hypovolemic, you obviously trigger the baroreflex, which increases your sympathetic nerves to increase heart rate, stroke volume, and all that. Now, at the arterioles, you obviously get vasoconstriction in order to try to raise the total peripheral resistance. Now, remember I said there's an upstream effect and there's a downstream effect. The upstream effect of sympathetic vasoconstriction is obviously to try to raise the blood pressure. BP is CO times TPR. But at the same time, when you constrict the arteriole, downstream, there is a drop in the hydrostatic pressure. And this drop, reduction in the hydrostatic pressure in the capillary, actually benefits the hypovolemic situation, because now you have a shift in the Starling's forces, the same person who gave you the mechanism of heart. So when there's a drop in the hydrostatic pressure because of vasoconstriction, the oncotic pressure is still unchanged. And so the shift of the net pressure here will favor a reabsorption of fluid from the interstitial fluid space into the vascular volume. And this is known as a transcapillary shift intermediate compensation to help to maintain blood volume. Okay, so let me move on to a few more concepts. So keep in mind that when we talk about the baroreflex response that involves the brainstem, this is what is known as a central homeostatic vasoconstrictor. It is actually complemented at the same time by a concurrent local vasodilation. Okay, this is central vasoconstriction to help to maintain blood pressure. But at the essential tissues like the heart and the brain, you want to have vasodilation when you are hypovolemic in order to maintain a sufficient blood perfusion. Okay, so so let me skip the next slide. But this is just to remind the students that one of the main purpose of blood pressure regulation is obviously to maintain blood flow to the brain, cerebral circulation. So when you think about the giraffe, obviously this mechanism to maintain adequate blood flow to the giraffe's brain is even more effective, right? So, so the heart and the brain are essential organs. So when you have a drop in the blood pressure because of drop in volume, you get a compensation to increase the blood pressure. And this is by vasoconstricting other non-essential arterioles, like in the skin, in the splenic circulation. But in the heart and the brain, you don't constrict those vessels. They have their own special auto-regulatory mechanism. Because if you constrict this as part of compensated increase in TPR, you will make the situation worse. Okay, so keep this in mind: the local vasodilatory response and the central vasoconstrictor response to help to maintain blood pressure. So, so this is again in this picture here. So you have, if you have a decreased blood volume, hypovolemia, you have a central baroreflex together at the same time with a local vasodilation, and in this case is to maintain adequate blood flow to the heart. You can substitute the cardiac here with the neurons, and this will also be the correct concept in physiology. So let me summarize in the last few slides certain information. We're talking about neuroendocrine integrated control. And one of the major organs we mentioned in the first few slides is the adrenal gland, the adrenal medulla and the adrenal cortex that secretes several hormones. So this is just a handwritten, hand-drawn. So here you are. So this is again, obviously a tool. Yeah. So this is the adrenal gland. You have the adrenal medulla, you have the adrenal cortex. So adrenal medulla, stimulated by sympathetic nerves, obviously releases adrenaline. And this is part of the sympathomedullary system that we talked about. Okay, important for heart rate and stroke volume. Now, the aldosterone is obviously secreted by the adrenal cortex. And this is through the Renin-Angiotensin system. And again, to remind you that sympathetic nerve stimulates the secretion of renin from the juxtaglomerular cells in the kidney. Okay, and then the cortisol, although it does not directly affect blood pressure, it actually does indirectly contribute to what is known as a vasoresponsiveness of the blood vessel. It makes the blood vessel optimally sensitive to vasoactive agent. And obviously we know that cortisol is under this hypothalamo-pituitary control. And we know that the corticotrophin releasing hormone is a neurohormone. So again, we are on neuroendocrine integrated control. Okay, so here you have in this on the left side, aldosterone involved in blood volume. This is the kidney, and here on this side is obviously on the right side is your cardiovascular. So again, this again highlights the cardio-renal integrated neuroendocrine control of blood volume and blood pressure. So put it another way, students may be interested. You can actually encourage your students to try to enjoy their physiology to draw in different ways. So this is just sympathetic nerve, the key role of sympathetic nerve in blood pressure control. Just to remind you, sympathetic nerve stimulates the adrenal medulla. Sympathetic nerves also stimulates the afferent arteriole in the kidney. Okay, afferent arteriole. Now, the constriction of the afferent arteriole by the kidney is not just constriction. Okay, it actually has three beneficial effects on blood pressure control. Okay, let me just summarize here. By constricting the afferent arteriole, it contributes to total peripheral resistance. By constricting the afferent arteriole, it reduces the filtered sodium load. And this obviously is part of the sodium balance control. Okay, and by stimulating the JG cells, which is part of the afferent arteriole, it is releasing renin, which is part of the angiotensin aldosterone system to conserve sodium. And obviously we know that in the medulla, the sympathetic nerve stimulates adrenaline secretion. So this is just another way to summarize information. So let me have just a few more slides, and then I should pass the time to Dr. Dono. So here is just to help students to map out. So these are all in A, capital A, the autonomic sympathetic system, the adrenaline, angiotensin 2, aldosterone, ADH, atrial natriuretic peptide, which is a peptide that increases this excretion of sodium when you are in hypervolemic. And this R, you want to make a guess what this is. This is R is the thirst mechanism. So I'll try to put the letter A. So the thirst mechanism obviously is involved in volume control, and that affects blood pressure. So, so let me give you another flow diagram in relation to ADH. So ADH, most of you associate ADH with osmolarity control. But don't forget that volume sensing also affects ADH secretion. So whenever you are hypervolemic, even though your osmolarity doesn't change, you can also trigger ADH secretion. So the next slide is just a little bit of supplementary information on the role of volume changes in affecting ADH, also known as vasopressin. Now, just to highlight here, so here it says venous, atrial, and arterial pressure, because in the venous system, in the atrial wall, and in the arterial system, you have actually families of volume receptors. So for example, listed at the bottom here, when we talk about volume sensing, it involves your baroreceptors in the arterial, because volume and pressure are related. When your blood volume changes, it also involves volume receptor. This is defined as on the venous side. And you also have what is known as the volume sensors in the kidney, the intra-renal volume sensors. Okay. So let me skip the next slide. And then, okay, this is, I think, my second last slide. So the volume sensors, which are obviously important in monitoring blood volume changes, involves a neural reflex as well as a direct response. Okay, neural reflex, we already said, is obviously your sympathetic nerves. So both the arterial baroreceptor, or volume sensors, and the volume receptors in the large veins and the pulmonary vessels will trigger your baroreflex. Okay, and this baroreflex is also this afferent impulses that activates your sympathetic effector response also stimulates ADH, and it also stimulates your thirst mechanism. So you find that you have actually supplementary impulses. And then lastly, the direct response is what we call the intra-renal volume sensing, or the intra-renal baroreceptor. And this is linked to the secretion of renin. And within the cardiac atria, the volume receptor sensing is also in the case of hypervolemia linked to the secretion of this hormone. So I hope that this big picture of the integrated cardiorenal neuroendocrine regulation provides a summary of important information. And as I said, I'm happy to interact with the students. You can get my WhatsApp number from Dr. Ratna. You're welcome to have it, and we can continue talking about some of this important cardiorenal physiology. So next slide is to show you that my grandson still can be happy in some occasion, and this is the celebration of her mother's birthdays. They're all locked down in Sabah, and I can't travel to Sabah because of, I actually need, although Sabah is part of Malaysia, I need the police permit, and I need the permit from Sabah to travel to Sabah because of the COVID lockdown. Yeah. So thank you very much, and be happy to pass the time back to the chairperson.
Yeah. Thank you, Professor Cheng, for your presentation. It is very interesting with this, all of the illustration also. I hope the students will get much information from it. Next, we will have a Q&A session first. Then there's like several questions in the chat room. May I read it, Professor? Wait a minute, like
Yeah, please.
share screen too. I'm sorry. Sorry. All right. So the first is from Yos Akbar Irmansyah. It's also in the chat room. Recently, we all know the mechanism of hypertension now from the RAS system due to its mechanism. The question is someone was diagnosed by the hypertension, do you agree if we should give the anti-hypertension for a long life if it's indicated, as maybe someone believes that there's no cure for hypertension and it's more likely control hypertension? Is it clear? Or...
Yeah, I'm not so, I didn't quite hear the question clearly.
All right, so wait a minute. Yeah. I would like to share the screen.
Maybe it might be better, yeah.
All right, I'm sorry. All right, this is the question. So if someone is diagnosed by the hypertension, do you agree that we should give the antihypertension drug for a long life? Okay.
Yeah, I'm not a clinician. I'm a basic scientist, but my impression is that, yeah, those with hypertension, they take antihypertensive for lifelong, yeah. It's actually symptomatic, yeah. So Professor, Dr. Dono perhaps will be able to add on some information later, yeah. Yeah, there is no cure for hypertension as far as I know, because sometimes it's due to either the vasoresponsiveness of the person's arterioles. So it's just a property, and they have to take it, yeah, regularly, yes.
All right, thank you, Professor. So for the next question is from Nimas. Which one is the most important between giving cardiovascular drug that could be worsening renal function or preserving function of renal in patient with cardiorenal system?
Yeah, so this is obviously a good question because it tells you that both the cardio mechanism and the renal mechanisms are involved in the control of blood pressure. So if you give a renal drug, it will have cardio complications sometimes. If you give a cardio drug, it might have renal function. So depending on the status of the patient, this will be obviously something beyond me to answer. And I suppose also sometimes the drug company promoting renal drug would say it's good. Drug company promoting cardio drug would say this is better. So and obviously there would have to be a consensus by the clinicians who are working with the patients to come out regularly with some recommendation. Yeah, but it's a good question. Yeah, definitely.
Thank you, Professor. Yes, I think there's like one last question, but still in the chat room. Wait a minute. So As we know, during the beta blocker treatment, our symptomatic system is going to be blunted during that period. Our heart rate may not rise as fast as usual, and also our blood pressure in handling and increasing activities. My question is, there's an effect or impact to our RAS system, our AS system?
Yeah, could you put out the words? Because
yes, wait a minute. This is the chat room. Or wait a minute. I think the chat room cannot be copied, so I have to yes, type it for a little bit.
Okay, right. Yeah.
Right, wait a minute, I will share screen first.
If I remember correctly, the stimulation of the renal sympathetic nerves on the renin release, you have to check this for me. I think it's on the beta receptor. This is a beta effect. Correct me if I'm wrong. When the renal sympathetic nerves trigger renin, I think that effect is on a beta receptor. So this question obviously has relevance to using beta blocker. Obviously, you want to modify the action on the heart. So there may be some modification also on the renin release. Yeah. So.
Okay. So this is like the very last question, Professor.
Okay.
All right. I'm sorry. This is for the last question. I ever heard that we should stop ACE inhibitor or ARB drugs before a surgery. Does there was a relationship between a surgery and these drugs?
Yeah, so there are obviously a pre-surgical requirement. These are for people who are hypertensive, right? So
yes.
Yeah, I'm not sure why they would do this. Yeah, I think any surgical phenomena is a stress situation. That's my impression as a physiologist. So thinking about it logically or physiologically, even though I'm not a surgeon, yeah, any surgical procedure is a stress situation. So that event already will raise the blood pressure. So so it might be something to do with that. I mean, I can't explain to you specifically why it's recommended, but it's a good question. Yeah, it is useful as a problem-based learning scenario, I think.
All right, Professor. Thank you very much for answering our questions. All right. I think it is enough for the question also because due to time limitation. So once again, for Professor Cheng, I would like to say thank you once again for joining us today and for your amazing insight and also for your amazing illustration. I believe it will be very useful for our students too. Thank you very much, Professor Cheng.
Thank you. Right.
Good morning. All right. So for the next agenda, we will move to the second speaker, who is also expert in the subject, Dr. Dono Indarto, Magister Biotechnology, PhD. So Dr. Dono is also a lecturer in the Department of Physiology, Faculty of Medicine, Universitas Maret. And Dr. Dono obtained his master and also PhD in Flinders University, Australia, with the field of molecular biology and biotechnology. Dr. Dono is also active in many publications with various topics, including biotechnology, biology molecular, biology medic, and also proteomics. So this morning, Dr. Dono will talk about the cellular and molecular effects of physical exercise on cardiovascular system. So good morning, Dr. Dono.
Good morning, Dr. Dyonisa.
Yes, okay, Dr. Dono. Yes, I'm fine, doctor. Thank you. So after this, Dr. Dono, I think you're all ready for the presentation?
Yeah.
All right, the time is yours.
Okay, thank you very much, Dr. Dyonisa. Okay, I will open my slide first. Okay, you can read my slide?
Yes, Dr. Dono.
Yeah, okay,
It's
yeah.
clear.
Okay, yeah. Okay, I make it bigger now. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Professor Cheng, for giving a lecture today. This is very interesting. And then my lecture today is about probably Professor Cheng is explain about the basic physiology of cardiovascular system.
Excuse me, Dr. Dono.
Yes.
I'm sorry. I want a little bit time. So
Yes.
for Professor Cheng, if you're still here, thank you once again. And you may believe the next session will be on the 10 a.m. and 10 a.m. in Indonesia. And you can leave first, or you can also join another Zoom. Thank you. I think it's already all right.
Okay, that's okay, no problem. Yeah. Okay, I will repeat my introduction first. Thank you very much for Dr. Ratna for giving opportunity to me to explain about the cellular and molecular effects of physical exercise. Yeah. Actually, Professor Cheng mentioned about the basic physiology of the cardiovascular system. And now I will explain about the applied physiology. Of course, it's about the physical exercise. Okay, let me start now. I will going to talk about the introduction first here. I think this is maybe it is relevant to the some student. I think maybe from the resident of the cardiology, or maybe it is from also for the medical student in semester 7. Yeah, you know about that about the cardiovascular diseases. Yeah, because right now, I think until now in 2021. The CVD, it is the leading cause of morbidity and mortality in the world. Yeah, so it's many factors. Yeah, but I don't mention one by one about that. Yeah, I just summarize about the epidemiology of the CVD. Yeah, it is almost 50% American people. This is at least. At minutes, so you can, yeah, you can see from the slide, at least have one risk factor of a CVD development. Yeah, this is many things. I will show you on the next slide, because from the last publication, there are 10 the risk factor for CVD. Here is we can see. The most important thing is that here is a high blood pressure, and then high cholesterol, or this is the lipid that is very high, or it is the smoking habit. Yeah, this is the most important for us. And the next one, yeah, I think I don't explain about the clinical sign about the CVD, but this is the most important, because if someone who have the high blood pressure, or maybe high cholesterol, or maybe smoking, this is the fatal risk, and is to develop probably the stroke, or maybe it is a myocardial infection, or maybe a cardiac arrest. So I think because we are, yeah, now it is still young. Yeah, maybe for the medical student, it is less than 30 years old. So this is the very important time, yeah, to prevent everything to develop to the CVD. So for the prevention of a CVD, we have some risk factor here. You can see here. I take it from the American Society for Preventive Cardiology. there are 10 risk factors. The most important from here, I will explain about the first and the second factors, not all of factors. Yeah, the first one is about the unbalanced or unhealthy food or nutrition, and the second one is about the physical inactivity or sedentary life. And the next, the remaining risk factor, it is related to the clinical manifestation. I don't mention one by one. Probably in the next slide, maybe I will take maybe the overweight and obesity, or maybe sometimes maybe I will explain about the probably the age, maybe ethnicity, or maybe the gender. And the last one, I think the last risk factor, it is maybe the rare the risk factor here. It is a genetic abnormalities. Yeah. If someone have, I mean, the history family, probably for the high blood pressure, or maybe there's a hypercholesterolemia, or maybe something like that. Of course, they have higher risk to develop the CVD. And this is the first one. I will explain about the nutrition. Why does the nutrition and the physical activities is very important to keep our heart. The nutrition, this is the external factors, yeah. Because if you see from this one, yeah, it is from the American, yeah. I mean, from the American report, you can see here, yeah, it is around 17.1%. 17.1%. It is for adult US people here have special diet. It means special diets maybe can be vegetarian, or maybe they just eating everything derived from meats, or maybe from fish, or maybe another special diet. But in general, yeah. But in general, from the last report, we see that the American people, now this is the same thing in around the world. In adult people, they have the bad habit. This is the consume much more or high energy, or maybe there's a like eating fat, and then maybe just consume less than the recommendation of the vegetable and fruits. And how about here, we can see from the Indonesia, I think that is the same thing. You know, but that the fruit and vegetable in Indonesia, it is a very, very rich country about the fruits and the vegetable. Yeah, many kind of fruit and vegetables we can find in any places in Indonesia, maybe in the traditional market, or maybe in the modern market, we can see it. So this is very important because those fruit and vegetables, this is containing just very important fibers, and then many vitamins, and also industrial minerals. And now we can see from the recent study conducted by Hermina and Prihatin that Indonesian people, this is only 38.8 grams fruits per day and 70 grams per day the vegetable. I think you know, but from the Indonesian Health Ministry, the recommendation for consumption of fruit and vegetable 150 grams per day. It is for the fruits, and then 250 grams per day. It is for vegetable consumption. So this is less than recommendation. And another report you can see from the data of basic health research 2018, it is also amazing. But this is also, I think, threatening for us because 96.4% Indonesian people, it is for the adolescents and the young adult, it didn't consume less fruit and vegetable. So this is terrible for us. So I think what is the, I'm interested for the next question. So what is the impact for this unhealthy diet? If you have a look at this one, it is from the US report. You can see the obesity prevalence in this rising and rising. If you can see in 1996, this is only 19.4%, but in 2018, you can see it is about 21.3%. So this is increased by 10%. It is in the US. How about in Indonesia? You can see here from the data of basic health research, you can see here the obesity, it is related to the age. The higher age, it is the higher prevalence of obesity. This is the same thing, not only in Indonesia, not in the US, but in all of country in the world. This is the same burden about the obesity and overweight. If I said before, it is a obesity and overweight is the risk factor for CVDs, and then you can see here the mortality rate between obesity and the CVD. So if you see in Indonesia, it is the the mortality rates here. It is around 7.5% to 10%. So this is, I think, for all of us, we have to consider about that. It is threatening for us because if we don't prevent right now, so many people in young age, maybe they will die prematurely. So that's why we have to prevent of that. We cannot avoid that, and then we have to do to improve our diet. Of course, this is the suggestion for us how to manage our diet in order to avoid the CVDs. The first one, if you can see from here, of course, sorry about that. The first one, we have to consider four things related to the diet. The first one is about the quantity. If you consider for the quantity, of course, we have to know about the body weight first, and then we have to the age, and we have to know about the activity. So this, and then we calculate how much we have to eat in daily consumption. And then the second one, and this is the quality. This is to ensure that everything we eat in this to keep our body as health. So you can see here, you can see from this the circle here, in the top left side, this is about the carbohydrate sources. So which one we have to do? And then the right, the top right corner here, it is the fruits and vegetable sources, and also this is the fish, but not the meat. And then if you see on the bottom here, so this is about our activity, and then which one we have to choose, and we have to educate every person or every people, people in Indonesian people, which one they have to eat in daily life. And the next one, and is the last one here, we have about the time. So we have to divide it into 3 times. This is the most important for us. Yeah. Because if we eat more than 3 times, this is tends to excess of the energy. That's why this will become obesity or overweight. That's why this is from here, 6 p.m. we have to stop eating everything until in the morning. So this is the time restricted eating. Yeah, and this around 40 hours. Yeah, this is the good time for us to maintain our body in a normal weight. Okay, now if we see from this picture, now this what is the suggestion here? The first one, yeah, we have to eat much more vegetable and then fruits. It is the most important. This is for the vitamin, mineral, and also the fiber sources. And then there's about the nuts, legume, and this grain seed. It is the source of carbohydrates. And then the fish. This is the it is rich of protein. And then the next one, we don't forget to eat the lipid. But in here, we have to consider it. The lipid here or the fat here, this is the unsaturated, not polysaturated. So this is the most important for here, this one. So which one is suitable for us? Of course, this is the vegetable oils. It is good for us. Yeah. And then the next one is the soluble fibers. I mentioned before, it is comes from the vegetable and fruit. And this is, yeah, we can eat it, we can eat them, but a limited number or a limited quantity. Yeah, this is about the saturated fat, of course. Yeah, this is the maximum we can eat for the salt. It is less than 2,000 milligram. Yeah, this one. And then cholesterol, yes, we can eat it, but it is just limit amount of the cholesterol. And the next one also. And now we are moving to the next risk factor. This is the physical inactivity. Before mention about this one, we have to know about the physical activity first. What is the definition? Because sometimes we confuse with the physical activity, physical exercise, and physical fitness. So from this slide, I will mention or will discuss about the physical activity first, and then what is the physical exercise or exercise, and then the physical fitness. If we can see from, we refer to the WHO in 2020, physical activity, this is the most important, because it is the body movement. It means all muscle in our body, it is will move. Yeah, whatever the activity, probably that is the daily activity, or maybe the exercise, or maybe the sports, or maybe something like that. But in here, if we doing physical activity, of course, we spend much more energy here, because if our muscle contraction, of course, they will need energy. Now, energy, this one come from our diet. And then the second one, if we do the physical activity, now we can measure with the metabolic equivalent of task or METs. Yeah, this is what is about the METs here. You can see here the one METs, it is the oxygen consumption during the rest time. If we just sitting, yeah, it is just sitting, no activity, nothing, yeah, nothing activity here, and then we consume 3.5 milligram oxygen per kilogram body weight per minute here. So from this math here, and then we can classify about our daily physical activity. Which one? It is sedentary life, or this is like activity, or it is moderate, or that is the vigorous activity. So if the mass less than 1.6, it means this is the sedentary life. If we are moving during our activity, maybe we are working slowly, or maybe we are cooking, or maybe we are cleaning our room and something like that, and this the math it is around 1.6 until 2.9, and then the next one is a moderate, it is more than 2.9, and the vigorous it is more than 6 maths. This is for us. Yeah, this is the classification here. It is too easy to memorize, so that we can which one it is suitable for us. And here I just give example for our daily activity and our maybe it is our habit. It is like this one, just lying in the front of the television, just watching television, so we can see what I mean what number or how much for the maths here. If we just lying here in the chair and then watching television, so this we can see the maths is just only 1. This is the IC before, it's a 1 maths. And then if you see the daily activities 1, it is less than 1.5. Except this one, it is standing. Yeah, this is we need much more energy. So this is the maths is more than 1.5. And then another example here. It is just physical activity. I don't say a physical exercise. It is if we do our daily activity, probably in the kitchen, or maybe in the garden, or maybe in our room. This is so many activity. Actually, we can see how much the maths here. It is more than 1.5 maths. So of course, this is the light activity. If this if the maths is more less than 3. Now here, I said before this one, this is we should be aware of what the sedentary life, because if sedentary life here, it means this is the maths is just less than 1.6. So there's almost no activity every day. So this is the dangerous for us, because this is become the risk factor for the CVD. Okay, now I will explain about the physical activity is less than 1.6 maths here. So we have much more energy for if we eat every day, for example, 3 times. So the balance become positive. We have much more energy, but for energy expenditure, it is less than 1.5. So this we have much more energy in our body, and then stored in the probably in the adipocytes, or maybe in the stomach. So this we now become obese or maybe overweight. If you see from this picture, if now we have obesity of overweight, this is the risk factor. Why this is the risk factor? Because for the accumulation of fat in our body, and this will induce our macrophage. If macrophage in this has become active, yeah, actually for healthy and someone who do the exercise, the macrophage and this become M2 macrophage type. But if we have obesity, we have accumulation of fat in our in our body. This is the macrophage, and this will shift to the M1 macrophage. If this has become M1, so this is we can see from this picture. The effect from this low grade chronic inflammation here, or maybe systemic chronic inflammation here. The first one, this has become insulin resistant. And the second one, it is for the immune cell, it has become the atherosclerosis in the blood wall, or maybe this has become dangerous in our brain, in the neuron. This has become the Alzheimer's disease. And another clinical manifestation for our body. And also here, we can see SCY in this one. It means it is a systemic chronic inflammation. I mentioned before, we have two things here. The first one is obesity, and the second one is physical inactivity. But there are many risk factors that can induce the systemic chronic inflammation here. For example, it is maybe chronic infection or maybe dysbiosis, because I said before, if we eat less fruit and vegetable, so the microbiota in our gut, so this is, I mean, the beneficial microbiota, it is a changes to the negative microbiota. So it means it's become dysbiosis, not as this the balance situation. So it means it's imbalance or maybe become bad. So this is also will induce the systemic chronic inflammation. And this also diet I said before, and so many things. So again, if in our body many systemic chronic inflammation, this will induce a clinical manifestation. Yeah, the first one is the cardiovascular disease I said before. Probably not only this one, but also maybe cancer, maybe autoimmune, or maybe in the neurodegenerative diseases. And then second one, I will explain about the physical exercise, or maybe just say exercise. But sometimes, in general, yeah, physical activity and exercise, this is sometimes this is overlapping. Oh yeah, I say exercise, but exercise, this is different with the different from the physical activity. Yeah. I said that before, physical activity is a body movement. Yeah. Whatever we do, this is the physical activity. But if we say exercise or physical exercise, it means this one in this we do with the specific time, or maybe it is a plan, structure, and repetitive body movement. So if we just doing the physical activity one time per week, it means this is not exercise, because it is a plan. Yeah. Now, I think the next slide we can see how many times you can do the exercise. That's an exercise. Structure, it means this is the body movement. It is with the not only we move our body, but this is the muscle, or the muscle in the maybe in the upper extremity or the lower extremity. We have the rhythmic movement. So it means this is the structure, and the repetitive. This is not only one. This is at least 3 times per week, maybe 4 times, and sometime like that. And then the last one is about the physical fitness. What is the physical fitness here? Physical fitness here, it is, you can see physical fitness here. Yeah, this is in the exercise physiology. We can measure the physical fitness using the maximum oxygen uptake or aerobic capacity. Yeah, physical fitness here. This is the same thing with the maximal oxygen uptake. It means this is the capacity our body to consume oxygen during the exercise. This is the physical fitness. Yeah, this is the measurement of our activity, or of physical activity. So this we can know which one, because from the slides before, we have a match this is the light, sedentary life, moderate, or maybe the vigorous or the hard physical activity. But another way, we can use the physical fitness to measure our body. It is a good physical fitness or not. Because if we have the bad physical fitness, it means this is related to the sedentary life. For the VO2 max or maximal oxygen uptake, usually we can use this one, milliliter per kilogram body weight per minute. This is the unit for our VO2 max. Here, if we see this one, the limits for our VO2 max, this is 15 milliliter kilogram per minute. If less than this 15, if less than, it means this is a sedentary life. So you can see from here, if we are getting old, for example, it is from the adolescent, from the children, and then going to the adult, a young adult, and then adult, and then probably the less or maybe more than 70 years old, the VO2 max here also will decrease depending on our age. If our age is still younger, the VO2 max in this will increase, and vice versa. If we are getting old, and then the VO2 max also decrease. So it is about the formula here. If we are 30 years old, and then this one, VO2 max will decrease around 10% per 10 years our life. We can calculate it. We can calculate how many reduction of our VO2 max. And then, if we want to know in detail about the physical fitness, many things will influence the physical fitness. This is just this is just the summary. The first one, this is the respiratory system, because this is very important to take oxygen from the environment and then come into our body, and then to distribute to the cardiovascular system, and then from cardiovascular system, from the blood, and then moving around the world, and then come to the our cell or our tissue. And the last one, it is the muscle metabolism, because different type of tissues, it is different type of metabolism. The most active metabolism in our body, it is the first one, it is muscle cells, and then heart cell, and then the neuron or brain cells. And then now, there is my question. Do physical activities have beneficial effects to our body, especially to the cardiovascular system? I don't mention about the exercise or physical activity, because that is the major subject in the semester 7. So I don't mention one by one. How many times, and then what about the intensity? What is the frequency? I don't mention about that. But if we do the regular physical activity or exercise, so what is the beneficial effects for our body? Look at this picture here. We have 4 categories here. The first one, it is the lazy person. It is the sedentary life. And the second one, it is a person have light or moderate physical activity. And then the third one, it is the good person, because he is or maybe she is doing the physical activity, but the physical activity her or he's doing, it is just in the short time, just maybe just once per week, but this is the vigorous activity, physical activity, I mean. Or the third one, or the last one, is the athlete. Yeah, this is the regular training for the person, maybe Olympic athlete, or maybe national athletes, or maybe the local athletes. This is the fourth thing. So if we see from the maths here, of course it is the minimum maths, and then this one, and this is the medium, and this little bit high, and this is the very high. So what is the benefit here? If you can see from the sedentary life here, there is no benefit, because everyone just lying, sitting, or maybe just sitting in the front of the computer and the laptop, or just watching television, there is no activity. So this is many things related to the stress in the body, especially in this the will produce or generate the reactive oxygen species. Yeah, basically we have antioxidant in our body, but in here, because the amount of the ROS, it is similar to the scavenger, so this is the balance. So now we don't have any beneficial effect from this activity. But if we are moving to the second one, it is light or moderate physical activity. So you can see here, the oxidative stress, it is become lower or reduced. But here the ROS, yes, it is will increase, but increasing the ROS here will induce everything in our body. So they will release some cytokine, but this is to maintain our body's health. But notice the negative effect on the ROS production here. And also here, the scavenger here, it is a probably this is one we can catalyze SOD or maybe glutathione. This is a good antioxidant for our body, so it is also increased in this. So that's why. So we have beneficial effect from this activity or physical activity. If we move to the next one, of course, we have much more beneficial effect from the physical activity. Here is, if we have good physical activity or regular physical activity, of course, all of organ in our body changes at a time. This is, for example, the first one, because it is related to the cardiovascular system, we have two things here. This is the heart and the vascular of the blood. If we see the heart, I will discuss about this in the next slide. The morphology is become bigger. So the cardiac function, it is also become good, or the cardiac function will improve significantly related to our exercise. And then for the vascular system, this one, yeah, it is for the endothelial cell line. Angiogenesis, or the mix or the produce or the generation of the new cell or endothelial cell, it is will improve. Of course, if this is improved, the angiogenesis, this is will limit or will reduce the atherosclerosis. And also in another organs, we can see here many things that is the beneficial effects of the regular physical activity. For example, here in the immune system, of course, this one will have beneficial effect. What is the beneficial effect here? Because this is will inhibit or maybe will reduce the inflammatory reaction in our body. You can remember that I explained before, many things producing in our body, it has become a systemic chronic inflammation because we are living in the environment, we are living in the earth, so many things can induce our inflammation. So if we do the physical activity here, of course, this is will regulate our immune system. This is not to increase the inflammation, but will reduce the inflammation state if we are doing physical activity regularly. And this is the first explanation, yeah, because if we have any stimuli from outside the body, yeah, this is, for example, I say this is exercise, because not only exercise can induce the production of the ROS, probably infection, you know, probably unhealthy diet, smoking, and something like that. It is also increase the ROS production. But here, I will explain about the exercise. Whatever the exercise we do, probably this is the aerobic, or maybe anaerobic, or maybe the stretching, or maybe walking, or maybe something like that. And the intensity, yeah. Okay. Oh, I forgot about this one. Sorry. I will go to the previous slide. Yeah. Yeah, this one. This one, but the intensity. Yeah, this is from the WHO. How many times we should do the physical activity? Yeah, this is around 150 minutes per week. But we can divide maybe 3 times, 4 times, 5 times on every day. Yeah, this is, you can see from the I mean, from the website of the WHO about the physical activity guidance. Yeah. So it is moved here, this one. Yeah. Here, intensity, duration, and frequency. Yeah. So this is will stimulate the ROS production. If the ROS production, it is very different, the reaction or the response our body. If that is the acute and the chronic exercise will have different responses. If this was, I said before, if this we just do the physical exercise in a short time, but the vigorous, this is, we have negative effect or disadvantage effect of the exercise, because this is acute oxidative stress will high and then will induce the muscle damage or the inflammation. So this is will impair our homeostasis. But if we do regular exercise here, the production of ROS, it is, yes, increased, but not too high like to the acute exercise. So this is will influence the cell signaling. Yeah, the first one maybe MAP kinase or maybe SAP kinase, and then will induce the gene expression that related to our new adaptation or the new situation related to the regular exercise. Here is this is the explanation, yeah, about the acute and the chronic. Yeah, if from here, from the chronic activity here, yes, the oxidative stress is increased, but this is will maintain our new homeostasis. So this is the condition here. The damage of maybe the cell damage, and this will decrease probably in the cardiomyocytes or in the myocytes, or maybe in our mitochondria, or maybe in the kidney, or maybe something like that. So this is we are now become resistant to the inflammation. But if we do the acute and vigorous exercise here, yeah, this is, we had not beneficial effect, but this negative effect. Yeah, this is probably our performance become decreased. I will feel fatigue. Maybe we have some clinical manifestation, probably maybe hypertension, or maybe it is headache or something like that. Now, we move to the next explanation, why there's a regular physical activity or physical exercise will decrease the systemic chronic inflammation. There is the three pathways here. The first one, it is will reduce the adipose tissue. So it means, if I said it before, if we are just lying, if we have sedentary life, this is conversion or shifting M2 to M1 macrophage. But if we doing the exercise, it is the macrophage now become M2. If it become M2, this is the immune cell system will become tolerance, not increase the inflammation. And about the here, if you see the immune system here, in the signaling of immune system, we see about the TLR. TLR in here, it means it is the receptor in the membrane of the cell. If we have a stimuli, everything from the come outside of our body, for example, infection, or maybe the heat, maybe pollution, or maybe smoking, it is will recognized by TLR, or the pattern recognition receptor. Of course, if we do the regular exercise here, this receptor not increase, it means this is become tolerance, or the expression is become down, or the exercise in this regulate or don't regulate about the TLR expression. And the next one, this one also, you can see, I think maybe from the student, the medical student 2018, because you have immunology block, or maybe about the immunology diseases, you know about the cytokine here, interleukin 6. Maybe you know, oh yeah, interleukin 6 in this pro-inflammation cytokine. Yes, if we have infection. But in here, if we do the regular physical exercise, the cytokine of interleukin 6, this will increase, but this is not come from the macrophage or come from the immune system, but this is come from our muscles. This is different. So two things we consider about then. Interleukin 6 can be pro-inflammation or can be anti-inflammation. If interleukin 6 come from the immune system, yes, that is the pro-inflammatory effect. But if the interleukin 6 come from our muscle cell, including the heart cell, this is become the good one, because this is become anti-inflammation effects. So it is here, yeah. If this is anti-inflammation, of course, this is the leading to the reduction of chronic systemic chronic inflammation. Yeah, here is for the cardiovascular system. What is the effect? Of course, the first one, if we are doing regular physical activity, of course, our physical fitness become high. If physical fitness become high, because we need much more oxygen, we need much more energy. So of course, our heart especially our ventricle, it is become large. And another one, yeah, of course, yeah, because I think maybe if you heard from the Prof. Cheng this morning, yeah, it is good for us. If we are doing the physical exercise, this has become large, stroke volumes become high, cardiac output become high, and then the heart rate not increase, but this is will decrease because it's even, yes, if we are doing the strenuous or the hard physical activity, of course the heart rate also increase. But here the most important here is the stroke volume or the enlargement of our left ventricle. And then if we summarize the effect of the regular physical activity on our body, this is the three things. The first one to our heart, the second one to our blood vessel, and the third one in our blood content. It means maybe erythrocytes, maybe the protein in the blood circulation, or maybe the hormone, or maybe the enzyme can be in. So here we can see it is about the effect in the heart. You can read by yourself here, the first effect, second effect, the last effect. So from this effect, yeah, I think from the heart, blood vessel, and the blood content here, and this will reduce the risk factor for our health. So it means the CVD will become going down. Because the last one here, from the effect here, the cardiac output will increase, the resting blood volume will decrease, and the oxygen will high. So it means our cells, our tissue, it has become health. So the risk for the cardiovascular diseases in this will down. Now, if we move to the our heart cell, here we have two things here. The first one to our hormone, and then to our cell. It means for endothelial cells, for the new formation of the blood vessel. And the second effect, it is to our mitochondria in the heart. Of course, if the mitochondria is high, of course the energy supply also high. So the heart will work efficiently. And the third one, the effects in our body, it is the immune system. Our immune system has become tolerant because our muscle will produce interleukin 6. The interleukin 6 will up regulation or maybe down regulation our organs. Look in the next slides. What is the effect here? Yeah, I think maybe in the next slides where I explain about that. And this is the cellular effects of our physical activity here. We can see the effect from the heart rate, and then stroke volume and the cardiac output. What is the effect? So we can see here from the time here, if we are going to do the activity, physical activity, it is in the short time or the medium or maybe in the long time, you can see what is the different the heart rate and then the cardiac output here. In the heart rate, yes, if we do the activity in the short time, the heart rate will increase sharply here. It is maybe around 10 minutes. Yes, it is will increase sharply. But if you continue to do the exercise and then more than 10 minutes and then 20 minutes, 40 minutes in this the increased heart rates in this become slowly, not so high compared to the 10 minutes, the first 10 minutes. If you cannot see from the stroke volume, this is the same thing. If we do in the short time, this is will increase sharply, and this increase sharply as well. But if we do more than 20 minutes, this is more, I think, remain or stable, the increase of heart rate and the stroke volume, or maybe in the cardiac output. And if you see the figure in B here, about the proportion of our proportion of blood in our organs. If during the rest time, we can send here, and it's the purple and the orange here, it is the most dominant our body to get the blood. If we doing the light, heavy, and maximal aerobic activity, we can see the proportion, and this is very changes dramatically. So this is the heart muscle here, the scatter muscle here become the dominant organ that receive blood from our heart. And then the next one, if you doing the exercise, because we have two type exercise, this is aerobic and the resistant. So this is very different effect to our body. Yeah, you can see here the growth of the our ventricle. And this the next one. So can see here what is the difference during our exercise here. The ATP production, because you know for the energy metabolism, yeah, for the energy supply in our heart, we have this three things here. The first one is fatty acid, and it's the first source of energy, and then glucose, and then lactates. Yeah, during we are doing the activity, we not rely on the glucose, but it is the fatty acid. It is the most important. And the second one is glucose, and the next. And then from the glycogen in our muscles. And about this one, yeah, this is also the production of the energy in our body, not only in the heart, but it is also in the skeletal muscle, or maybe in the adipose tissue. This is also using the fatty acid in our adipose tissue, but in the skeletal muscle, it is using the glycogen. It is the most important source of energy. Now we move to the last effect of the
I'm sorry,
physical
Dr. Dono,
Yes.
you're 5 minutes more.
Yeah, okay.
Thank you.
Now, because we have learned, we just learned about the physical activity on the cellular effects. Now, what is the molecular effect of the exercise? This is the summary of our exercise. If we do the physical activity, it will stimulate our signaling, especially in the heart, in the skeletal muscle, and in the blood vessel. So this will regulate the gene expression. So everything will changes. Why this changes? Because this is for the new adaptation, or for the adapt to the new response here. This is the effect. Yeah, I said it before. From the muscle here, it will produce the interleukin 6. Interleukin 6 in this will stimulate here the adrenaline and cortisol hormone. This will decrease or will inhibit the TNF alpha. This is the cytokine pro-inflammation, and also in the adipose tissue, and then in the lymphoid organ and other lymphoid organs. So now, so we move. If we are doing this one physical exercise related to the immune response, this is we are become tolerant because this is because our surface receptor TLR, it is become tolerant to the antigen or to the stimuli, and then also the TLR here in this mediating of the mediating of the stimulus here, it is also will degrade or will internalize. So this is will also will have our health. Of course, this is the here in the bottom here, we will produce the microRNA, and this is also stop or decrease or don't regulate the TLR expression. This is also to improve our microbiota in our gut, and this also modulate our gene expression, especially in the epigenetic or DNA modification. This is also the effect here. I think maybe I've moved here. This one. This is the last slide, I think. Okay. This one for the exercise here. Here doing exercise, our adrenergic receptor it is become high. It is beta receptor, could be beta 3, and then also this is the insulin growth factor. It is also high. The receptor in this from the neurogelin also this is high. This is to improve our heart because this is will reduce the hypertrophic pathology of our heart. This is to improve our heart physiologically, and also this is will stimulate the proliferation. And then also about the mitochondria, this has become active, because it will provide the energy for the heart. And now I think I don't mention one by one in the molecule because the time is limited. Now this become the conclusion. This is the conclusion from our talks this morning. This is the physical activity. So what is the what is the effect to our heart? This is this one. This is two, because if we do the physical exercise regularly, and this will produce much more insulin growth factor 1, and it also produces neurogelin 1. And this will interact with a receptor in the cardiomyocyte, and this will multiply the mitochondria in the heart. And this also will produce the protein kinase AMPK, and then also here will improve our blood because it is will synthesize or will release the endothelial nitric oxide synthase, and this is good for our blood. And the last one, it is everything in here in our cardiomyocyte will process in this one, especially in microRNA. This is will reduce the apoptosis in our body. I think that's all for our. That's all my talk today. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Dono, for your interesting presentation. And now we will go next for the Q&A session. So we have questions in the chat. From Farhan Hilmi, why does macrophage shift into M2 in obese humans? Perhaps Dr. Dono could re-explain its consequence.
Okay, this is opposite. Yeah, if we are obese, the macrophage not become M2 but become M1.
Right.
Yeah, M1. This is admin in this for inflammation. If you can see the I mean my slide. M1, yeah, M1 is related to the inflammation process, but M2 this is for healthy people or we doing regular exercise.
All right, thank you, Dr. Dono.
Yeah, good.
Maybe we clear the questions.
Yeah,
all right,
yeah.
Maybe for other questions, maybe for semester 7. who took the kedokteran olahraga, you may answer you may ask.
You can use bahasa if you don't want to in English.
Yes. Mungkin mahasiswa semester 7, silakan adik-adik. Atau mungkin dari semester yang lain juga tidak apa-apa, adik-adik. I guess.
2020.
Perhaps they may understand or still obtaining the information, Dr. Dono.
Okay, no problem.
Yes, all right. Well, maybe if there's no other question, I think it's enough from Dr. Dono.
Yeah, okay, thank you, Dr.
Yeah.
Dyonisa.
Yeah, thank you once again, Dr. Dono, for your presentation and also joining us into the international guest lecture. I'm sorry for interrupting in the beginning, Dr. Dono.
Yeah, don't worry about that.
Thank you. All right, so we will at the end of the international guest lectures today. Thank you very much for all of the participants for the participation. And once again, behalf on the entire committee, I would like to apologize for all the mistakes of today's event and if there's any mistake or everything. So I think I will close the event for today. So thank you everyone. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Dono, once again.
Yeah, thank you very much, Dr. Dyonisa. Okay, can I leave now?
Yes, you might, Dr. Dono. Thank you. Thank you very much.
Yeah, okay, I have another meeting. Yeah.
Yes, thank you.
Yeah, okay,
Thank you for your time.
Yeah. Salam semuanya adik-adik ya. Nanti mungkin di semester 7 diulangi lagi.
Baik, dokter. Terima kasih, dokter.
Ya.